Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
Welcome to the Concussion Corner podcast. My name is Dr. Jessica Schwartz, and I'm thrilled to have someone who is quite unexpected to be on the Concussion Corner podcast today. Her name is Dr. Lorelei Lingard, and she is an internationally recognized researcher in the study of communication and collaboration on healthcare teams. She is professor in the Department of Medicine and director of the Center for Education, Research, and Innovation, both at the Schulich School of Medicine and Dentistry at Western University in Canada. With a PhD in Rhetoric, Lorelei brings a unique approach to the field. For almost 20 years, she has studied the communication practices of clinical teams in order to support evidence-based educational initiatives to improve teamwork. In recent years, Dr. Lingard has been using her research on teamwork to shift the discourse of competence in medical education so that we are paying attention to not only individual competence, but also collective competence. In 2014, Dr. Lingard was awarded the prestigious appointment of Fellow of the Canadian Academy of Health Sciences in recognition of the impact of her work on Canadian healthcare. In addition, she is also an author of a wonderful book entitled The Question of Competence, Reconsidering Medical Education in the 21st Century, The Culture and Politics of Healthcare Work. Dr. Lingard, welcome to the Concussion Corner podcast.
Thank you.
You know, it's wonderful to have you here. You know, the Concussion Corner podcast essentially is geared towards healthcare professionals, so you are very much welcome into this conversation, of course, but really specifically targeting the injury of concussion. And I know that, you know, for a lot of our listeners, it might be a little confused present moment, but just to let our listeners into a little bit of my history with Dr. Lingard and Lorelei's impact on my career and my trajectory of where I've taken my career the last 5 years. So Lorelei was the opening plenary for the International College of Residency Education, the ICRE, through the Royal College of Physicians in 2014. And that was during my injury where I had time to soak up information and try to keep sharp during my concussive injury. And I had the privilege to actually watch her live, and this is on YouTube, and I'll make sure to put all the links up there for her, both her TED Talk and her opening plenary for ICRE in 2014, as well as a few other links. But what she was discussing was the concept of individual versus collective competence and the maze of disconnected care episodes our patients were experiencing in healthcare, both in Canada, and the same is true in the United States as well. And that was my aha moment, and that was my, okay, I know what I'm going to do now moment after hearing her speak. And I was just so inspired, and I'm so thrilled to have her on today. And that is basically the impetus for me to have started the world's first concussion education program for doctors and clinicians once I was made privy to that 2015 was the first formal didactic year that neurologists had training in concussion. And so this is an all across healthcare conversation of we are undereducated and we really have no entry-level education on the injury of concussion. And 2012 was the first international year that we started talking about the cervical spine and neck in the concussive injury, which I, as physio, we've discussed forever, but we've just had international consensus in 2012. And 2017 was the first formal year that we've internationally had a consensus that the concussion is a rehabilitative and treatable injury. So it is really with my absolute pleasure to introduce you to Lorelei Lingard. So Lorelei, welcome to the podcast.
I'm delighted to be the first rhetorician on your podcast.
Indeed. And maybe the only, because I'm unaware of your people other than yourself.
There are more of us. Maybe you'll have more.
Okay. All right. No problem. So, you know, I really appreciate you taking the time on to come on here, and I'm so thrilled to give a lens to our audience to another viewpoint. I know you are often involved with our physician colleagues and friends, especially our emergency medicine colleagues, but it's really wonderful to have you on. So just a little introduction of yourself. I start every podcast off with Simon Sinek's, why. We start with why, and we lead there. So I'd love if you can just kind of give the listener a little information of, hey, this is why you pursued your PhD in rhetoric, and, why on earth you would want to listen to physicians have conversations in the OR and so on for almost 2 decades.
Sure. So it's been about 20 years since I completed my PhD, and I think my why was I've always been interested in language. I come from a house of folks who are interested in language. My mother was a high school English teacher. I was always good at English, but I was never as interested in the literature stream of things. And then I stumbled across rhetoric. Rhetoric is the study of the social uses of language, how we use language to get things done together. And that fascinated me from the get-go. I started out doing my master's in advertising, obviously a very powerful social use of language. But at the PhD level, I became interested in medicine. And the question for me was really about communication. That was a time when medicine was devoting a lot of attention to how physicians communicate with patients. But almost nobody was asking, how do physicians and health professionals communicate with one another? And if you think about it, we spend at least as much and maybe more time communicating amongst ourselves about patients as we do communicating with patients, particularly in acute care settings where I did my research. So I started out just wanting to know, how do you people communicate about patients, and what's the role that language is playing in the care delivery you're trying to do? And then fast forward about 12 years, when all of a sudden in medicine, we started to hear the word competence. Rhetoricians are very interested in powerful words, and competence became a very powerful word. Competency-based education, competence by design up here in Canada. So I began to listen to the use of the word competence and realize that we're only usually talking about individual competence and rarely, if ever, thinking beyond that. And that's when I started to think not only about communication, but also about the question of what is competence at the team or collective level.
Indeed, and that was so powerful for me. I had, in 2011, I was one of the first 6 in New York City, I think we were the first 6, to do a residency, a postdoctoral residency in orthopedics as a physio with NYU, New York University. And when you were discussing the individual competent clinician, it makes complete sense. We've all, in the last 20 to 40 years, have become specialists in something. But again, we've become so honed in on our specialty as a clinician, we often forget to look at that 30,000-foot view of our patient as well. That collective look, using your language, from head to toe, including the biopsychosocial components of what may be going on with this patient with this injury in front of me. So it was really wonderful to hear you discuss that, and that kind of triggered me to lean in when you were, doing your 2014 plenary.
Yeah, I think one of the things that became really clear to me that needed to be explicitly argued was, of course, individual competence is necessary. Of course it is. But it's not sufficient. And making that logical step to say, yes, we've been focused on training individuals so they're excellent, and there's good reason, organizational, financial, medical, legal, that we focus that way, but it's not sufficient for today's care delivery setting when in many conditions, and obviously it sounds as though concussion would be an iconic one, a patient is not going to be cared for by an individual clinician. They're going to be cared for by a collective of them. And so we better figure out what that degree of competence looks like.
1,000%. And, you had a wonderful discussion that one of your key talking points was that no one clinician in 2018 or 2014 when you were speaking, no one clinician can comprehensively care for the patient of today. And that's so important to connect to. But now that we don't have that older white-haired gentleman that we associated with our primary care physician that really took care of everything, right? 100 years ago, if not, 50 to 60 even. We now have teams of, hospital teams. We have outpatient private practices working with hospital teams. We have so many things that have gotten in the way. So I really, connected to that as a rehabilitative team approach when you were talking about that. Was it Isaac Luke that you were discussing in that? Sir Isaac Luke, I think it was.
I don't. Well, yes. So there is a painting that I often make reference to from the late 1800s. I wonder if that's what you're thinking about. Mm-hmm. Sir Luke Fildes with that representation of the doctor and the patient. And I use that as a jumping off point to say, that connection, that relationship is still really key, but it's not the only relationship. And in fact, I don't know what your data are in the U.S., but probably similar to ours in Canada. About a quarter of Canadian seniors have 3 or more chronic conditions that they report, that they acknowledge and report. And those seniors report over 13 million healthcare visits a year. So, patients are not being cared for by an individual physician, and we have to reorient education and assessment and everything to reflect that reality.
Indeed. And so I would like you to kind of I know we've mentioned it briefly, but take the audience through, our listeners through, just once again briefly, what is individual competence, what is collective competence, and then maybe discuss your patient Joe that I'll contextually bring into concussion connection after you finish there.
Sure. So individual competence, it's such a commonsensical notion that we usually just call it competence. We don't usually call it individual competence. Mm-hmm. And what individual competence is, it's this notion that competence is something that an individual possesses in their mind, their cognition, their knowledge, in their hands. They possess a certain set of technical skills. We also talk about competence as a set of attitudes that we want individuals to possess, values. And because it's something that you possess, we also talk about it as something that you can you can acquire. So trainees come in empty. We fill them up with competence. We stamp them as being full of competence, and we send them off to practice. So it's the idea that competence is something that the individual possesses, that you can acquire, you can fill someone up with it, and then that it's context-free, that if someone is competent in one hospital emergency department, they'll be competent in another hospital emergency department. And in fact, our whole sense of regulation and licensure depends on this notion that competence is something that individuals possess, and it's not going to change from context to context. So that's individual competence, and that's how we do everything at the moment now in health professions education generally, but in medical education specifically. We look for the best and brightest individuals. We try and fill them up with the knowledge, skills, and attitudes they're going to need, and then we assume that they'll carry those with them wherever they go to practice.
Indeed. And then we have collective competence.
So collective competence is not an individual capacity. It's a distributed capacity of a system. It's not reducible to an individual, and it's dynamic. It shifts and evolves because it's strongly tied to context. So these are two ways of looking at competence. They are not mutually exclusive, and one is not better than the other. Kenneth Burke has this wonderful saying. Kenneth Burke is a 20th century rhetorician. He has this great saying, every way of seeing is a way of not seeing. So both individual competence and collective competence are ways of seeing. They both give us access to some important pieces of competence, and they create blind spots for us related to others. So individual competence can be really valuable. We can find out where people need to develop particular knowledge, skills, or attitudes. But collective competence can also be very valuable because it helps us understand situations where individually everybody on a team has the knowledge and skills and attitudes required, but put together, they do not perform competently as a collective. Mm-hmm. Individual competence doesn't set us up to grapple with that, and that's a daily reality in healthcare.
Indeed. And, I think we make the joke in healthcare, if a clinician cannot communicate with the patient, then maybe they should go into like radiology or something along those lines where they're locked up in a dark box or things like that. But I think that also ties into my world. I was a junior executive when I was promoted to a junior executive, I should say, when I was hit by a car in 2013. October 3rd, 2013. And so much of my training from my residency, unbeknownst to my residency site, based off of where I was working in New Jersey, was actually based on emotional intelligence. And we talked about leadership and EQ, like, social intelligence, emotional, like just out my ears. But it absolutely set me up for success as a clinician, because then I was able to hone in and focus, taming down the human emotion and behavioral things that happen with patients and things like that, so I could hone in and do my job as Dr. Schwartz. So it was really so eye-opening to hear those definitions of both individual and collective competence. And I hope, like, our listeners right now are either driving to work or at the gym or taking a walk with their dogs, and kind of listening in and nodding in, like, oh yeah, I know someone that's really very, like, intelligent from an IQ standpoint, but their EQ is just a hot mess. Their emotional intelligence, which I can imagine would be an issue with collective competence in teams. Have you looked into much EQ in your work?
Not specifically, because my work tends to be oriented not towards psychological constructs, but towards more sociological constructs. So those two disciplines kind of run in parallel tracks, and they have their own words for similar ideas. So EQ isn't something that I look at necessarily, but you're definitely right on track that emotional intelligence is part of what helps us with relational aspects. The thing I say about collective competence is that it draws our attention to the fact, which arises from complexity science, actually, that in a complex system like a healthcare team, the relationships among the parts are more important than the parts themselves. And EQ is about being attuned to relationships among the parts.
That was beautifully stated. Okay, so the listeners kind of tuned into individual competence and collective competence. Maybe they've never heard these things before. And now, can you actually kind of take them through, and just for our listeners to kind of lean in a little bit here, Dr. Lingard's breakdown of this patient, Joe, who is a diabetic patient that essentially gets mismanaged by the healthcare system because, like she said, most of our patients have more than 3 or more comorbidities. This is the aha moment for me in the way in which I created the Evidence in Motion Concussion Management Certification, which I was awarded an award by the Brain Injury Association for, because it is the world's first post-professional year-long and interdisciplinary program for concussion. So I would love for you to take the audience, Lorelei, through Joe, maybe in the next 60 to 90 seconds, just to kind of break that down and who he is and how he got mismanaged. And then what we'll do is I'll tie that in contextually to what a concussion patient looks like in 2018.
Yeah, I think that's a great idea, because I have lots of these clinical stories, and the goal is that I try and get audiences to think about what's a clinical story in your experience where there's lots of individual competence, but you pull it all together and it's not effective healthcare. So let me walk you through the Joe story. Joe's an 80-year-old man. He lives at home alone since his wife died a year ago. He had his first heart attack when he was 55, and he's had 3 others since. He's had diabetes for 25 years, and as a result, he has some mild kidney troubles. About a month ago, Joe was admitted to hospital with a pneumonia, and his kidney troubles worsened due to a drug side effect. Because of that, the doctors in the hospital stopped one of the pills, and Joe recovered well, and he went home. About a week after his discharge, he had a follow-up appointment with his family doctor. The discharge note from the hospital hadn't arrived at the family doctor's office yet, but Joe brought with him his pill bottles, including the stopped pill, which he's restarted because he didn't understand that he shouldn't. The family doctor at that appointment notices that Joe's blood test results from before his hospitalization raised concern about his sugar control, so the family doctor refers him on to his diabetes specialist. A few weeks later, when Joe visits that diabetes specialist, the specialist shares the family doctor's concern about the sugar control. He's worried that the current meds aren't working well enough, so the specialist starts Joe on a new sugar control medication. Driving home from that appointment, Joe fills that prescription at a different pharmacy than the one he usually uses. And as it turns out, the new medication for sugar control is not safe in the context of kidney failure. If the specialist had known about that worsening kidney trouble in the hospital stay, he wouldn't have started that medication, but a copy of the hospital discharge note is, of course, not sent to the diabetes specialist office. Now, Joe has daily home care, and in the past few days, since he started the new med, The home care nurses had noticed that Joe's having some sweating and shaky episodes. They wonder if it might be related to a low sugar reaction. But Joe doesn't check his sugars regularly, so they advise him he should talk with his family physician, and they note it in the home care binder, which lives on the kitchen table. A week following the start of his new drug, Joe's daughter comes to take him to church. And when he doesn't answer the door, she lets herself into his apartment, where she finds him in bed, having a seizure. The paramedics correctly diagnose him as having a profoundly low sugar reaction. They initiate treatment, and they take him to the emergency room. And usually when I tell this story or another one, I ask the listeners, what's going on here? Does this sound familiar? And the whole room fills with nodding heads. Joe got competent care from the hospital physicians, from the family doctor, from the specialist, from the pharmacist. Each of those individuals acting with the most up-to-date information available and within their own scope of practice provided competent care for Joe. But the sum total of those care events is not competent health care. And that, my kind of concluding remark is that, the reason that is because individual competence does not equal good health care.
Indeed. And I hope every one of our listeners is kind of either grinning or thinking to themselves of their own patient encounter, where essentially you kind of have to become a care manager for these folks. You have to advocate for these N of ones that are coming through your door, that are the Joes of this world. And Lorelei, I see this all the time. I mean, Joe is the majority of my patients, especially that geriatric population. So for our listeners to connect to this for concussion, and this was my aha, like Oprah moment. I don't know if you can picture that GIF where she's in red and she's got her hands, and I was like, oh my gosh. And I was literally watching you speak, and I really do believe in filling other people's buckets to make our day, go better. And I hope this fills your bucket, Lorelei. But I sat up. Yeah, I did. I sat up in bed and I was like, oh my gosh. And I want to make sure we keep this in a PG rating, but I probably said I'm a New Yorker. I probably said something else, but I was like, oh my gosh. I was like, this is genius. I was like, this is what's wrong with concussion healthcare today, and so many other paradigms of healthcare as well, by all means. But I started the Evidence in Motion concussion program, and I do what I do nationally and soon to be internationally when I speak based off of this concept. So essentially what happens is, and why I do what I do, and I'm really trying to embrace foam ed with this podcast to try and mini recreate what I've done with Evidence in Motion. Now, Lorelei, that's a year-long program. They have 52 weeks to complete. You're looking at 40 weeks of hard didactic education that's online and interactive. It's not a plug-and-play situation. And then we have discussion boards and live virtual rounds where I bring in patients from all over the world and talk about their post-concussive syndrome, essentially how they were mismanaged, very much like your Joe, in the concussion realm. And now this story, Lorelei, is the same story all over the world. Doesn't matter what healthcare system you're in. Doesn't matter where you live. Are you in a rural situation or a very, city population situation? It's the same story. So I was watching this both as a patient and a clinician at the time, and I was like, oh my gosh. I was like, we are mismanaging concussion patients of today much more prevalently than we are taking care of them well. So I said, well, goodness gracious. So like your lovely folks in Canada, we have the Canadian CT head rule, Ottawa ankle rules, things like that. And everyone's looking for a clinical prediction guideline to kind of help them clinically with everything that's walking through our doors, because we know that no one clinician can competently care for the patient of today. So with concussion, for our listeners to kind of lean into, and maybe for Lorelei to learn as well, UPMC, University of Pittsburgh Medical Center, sees about 20,000 patients per year just for concussion. And what they're doing is they're putting out white papers and free open access education for folks to tie in to connect to. So they talk about 6 clinical trajectories. I will add my own as well, 7th. But they talk about the vestibular components of a concussive injury. and ocular motor components, and we know that 2/3 of the brain's pathways are devoted to vision, and that 70% of our sensory environments are you come through our visual pathways. So again, very much so, if you're taking in muddy information, very Norman Doidge-esque, muddy in also means muddy out. We have the cognitive component of a concussion clinical trajectory, post-traumatic headache and migraine, which is up to 94% of athletes that get a concussion have a headache post-concussion, the cervical spine, and anxiety and mood. Now, I also add the exercise and autonomic dysfunction post-head injury as well, post-concussion as well. So if we're looking at about 7 trajectories, 5 of 7 of those trajectories are rehabilitative injuries that we can individually competently treat. So you could treat the neck, you could treat the vestibular system, you could treat the headache, you could treat the eye issue, but you have to collectively look at that patient as a whole and treat all of the things. You can't just treat, and I use just very purposefully there. You can't just treat the cognitive issue, because if the cognitive issue is coming from a chronic pain source, a vestibular source, an ocular motor source, a post-traumatic migraine source, all 4 of those have an anxiety overlay, and it may be they just can't concentrate. It's nothing to do with their actual cognitive skill sets. They're just in pain, or they're just not feeling well and they can't concentrate. So this concept of Joe is basically most of our patients out there, because most of them that are 65 and over have 3 or more comorbidities like Lorelei was speaking about. And then most of our concussion patients do not present with just one trajectory of just a vestibular issue or just an ocular motor issue. It's usually 2, 3, 4, if not all 5 to 7 things at once. So that's essentially why I created the program and why I speak and teach the way in which I do, because it's essentially I, as individually competent physio, need to understand what you, as individually competent physician or neuropsychologist or OT or athletic trainer or speech-language pathologist or anyone else in the trajectory of care, I need to understand what you do, you need to understand what I do, and then we need to understand what we can do together to treat this patient, because no one provider can competently care for a concussion patient of today. Does that sound familiar, Lorelei?
Absolutely. Concussion, I mean, you've taught me a lot about it. I didn't know much about it except as a mother of boys who played hockey. Mm-hmm. But it sounds like really an iconic instance where collective competence is necessary, that you can't move forward with healthcare delivery in a competent way without it. The other thing that I would flag from hearing you speak about that is that some of our research in the last 5 years or so has been trying to take this one step further and say, okay, if it's the relationships among the parts that matter, can we in particular clinical contexts understand where those relationships might be challenging or problematic so that we can target them for collective competence? So for instance, in advanced heart failure, where we've done a large research study across the country, one of the things that becomes very clear is that the relationship between what the nephrologist does and what the cardiologist does can be quite problematic, because what's appropriate clinical intervention for the one is going to undermine what the other one's trying to do. One specialist wants the patient wet, the other specialist wants the patient dry. So in concussion, are there particular relationships among some of those 7 parts where you would see recurring issues of people really need to understand how their clinical actions might actually be rubbing up against somebody else's?
Yes, and whew, man, I could just give you a high five and all the things for that. So 1,000%. So what we're seeing is that folks that are very neurologically acutely sensitive, for example, our vestibular, our ocular motor, I'll just hone in on the vision because a lot of people don't connect to vision. And we have neuro-ophthalmologists and behavioral optometrists who specialize in this, and we do have physios and occupational therapists who are also trained in treating this from a rehabilitative standpoint. Now, if you think about the brain, it's an only child like myself, although I try to play well with others in my career and in my social, professional, and personal life. I think my mother would say I do okay. But if you think about it, it's an only child. It's very energy, blood, glucose hungry. About 20% of our total caloric energy, depending on what we're taking in, goes to the brain. So if you're looking about 1,500 to 2,000 calorie diet, you're looking at about 20% of calorie going there, about 500 calories. And then just from vision alone, Lorelei, 2/3 of the brain's pathways are devoted to vision. So vision takes up an incredible amount of energy. And what we've found, and what I found anecdotally in my career, is that in medicine, historically, when we don't know what to do with a patient, we send them down true trajectories. We allude to them that they may be malingering or faking it because I, of course, this is sarcasm 101, as Dr. Schwartz, don't know what's going on with you, so you must be faking it. And then the other trajectory is that I then send you to psych, and I am alluding that it's all in your head and you just need to talk it out. Now, these themes we've seen very similarly with, for example, women and cardiogenic issues. So with heart attacks, just as 10 to 20 years ago, our emergency physicians in our hospitals in the ED were prescribing anxiety medication to women who were presenting with signs and symptoms of a heart attack. So we've seen this historically in medicine, even with like gonorrhea and syphilis. Like a little penicillin goes a long way, but those patients presented initially as psych patients. So again, unless we know what we're looking at, we don't know what we're really looking for. And that's kind of what was happening with this concussive injury, which is why in the last 5 years, we have exponentially grown with systematic reviews and things like that. I can still confidently say there is no evidence-based medicine for concussion today in 2018. Most of our papers are done based off of small n's of 10 to 20 and are consensus-driven. All of our statements are consensus-driven, that I can say factually. And for our listeners to also connect to is that there are over 43 working definitions of concussion, only one of them is evidence-based, and that we actually have no consensus on what a traumatic brain injury is, which is why there have been 0 phase 3 clinical trials for traumatic brain injury in this country in over 30 years. So again, we have to really, come down to the basics so we know what we're looking at. But what we do know is that this is a rehabilitative injury and that we can individually rehabilitate in conjunction with the other things going on, the other trajectories somatically, which often do affect the anxiety and mood and the cognition as well. So that will help for long term. But again, that's my tangent there. But yes, so 100% to your comment there. Now, what do you see in the future for we're about at the 30-minute mark here, Lorelei. What do you see in the future for your work of where you're going to be taking this concept of individual and collective competence and what you're going to be looking for in teams in the future?
Well, so one of the pressing challenges is to find a way to assess collective competence because we pay attention to what we can assess, and trainees pay attention to what we can assess. So at the moment, assessment of competence is, I can safely say, entirely individualist. Psychometrics doesn't like collectives. It doesn't like noise. It doesn't like relationships between variables that aren't well described. So we have a lot of work ahead of us developing some measurement models that could authentically and reliably capture collective competence so that we would have a way to say, this collective is competent. Oh, look, you take this person out of this collective and put another person in. Let's say in July in Canada, you change up the residents on the medical team. What happens to the competence of the collective? We know, anecdotally and experientially, of course, that the reason that you can survive a July 1st admission to hospital is because there is something called collective competence. If there wasn't, we'd all be in trouble. We don't have a way to measure that. So I've been working in the last couple of years with some measurement experts trying to figure that out. And it is a place where we don't even have any models, let alone any tools. So there's a lot of work to be done there.
And, where can folks find, I know you sent a great PDF over to me from 2016 entitled Paradoxical Truths and Persistent Myths, Reframing the Team Competence Conversation. And for our listeners, it's a very easy read. It's 2 to 3 pages, including the references. Is that free open access? Is that something that folks can access freely at this point?
I believe it is. Yeah, I believe it is. And the reason I would love people to write that or to read that is that we didn't have a chance to talk today about there are some safe places we go to when we say, okay, yeah, I believe in collective competence, but, and that paper really tries to grab those but statements and say, wait a second, these are myths about teamwork and we need to face them down or we're not going to make any progress here.
Indeed. And again, I expect that folks to listen in to be skeptical. We're trained as doctors of anything to be skeptical, right?
Absolutely.
But again, I hope to have you on again, Lorelei, to just get even in more depth of why your work is so important. I think we've definitely inspired more than a few folks to hopefully lean in and look into your research and work. What I'll do for our listeners, Lorelei, is I'll link them up to your TEDx talks. I will link them up to the ICRE opening plenary from 2014. What's the best way for folks to reach out to you?
Twitter is probably the best way.
Yeah, I concur. And what's your Twitter handle?
I believe it's Lingard.Lorelei.
Yes, it is. So at LINGARDLORELEI, at Lingard Lorelei on Twitter. And what I'll also do for our listeners is to link them up to your book as well. It's available on Kindle, hardcover, paperback, on Amazon. It's very easily accessible. And I'm in New York City and I do everything with Amazon Prime, so it's also available on Amazon Prime as well.
That's super. Thank you so much for having me. I really enjoyed the conversation.
I did too, and thank you so much for the work that you're doing. I sincerely mean it. I know that based off of what your work has been and where I've been introducing folks to your work as well, I can confidently say that your work has inspired just countless of folks in the concussion realm, so I appreciate you as well.
Thank you.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.